You can start, Dr. Stieg.
Good afternoon and welcome to This Is Your Brain, the Lower Brain. I'm proud, honored, and extremely happy to have two distinguished guests with us today, Dr. Ricky Singh. We can switch to the next slide, please. And Dr. Neel Mehta. Dr. Singh is the Vice Chair and Associate Professor of the Department of Rehabilitation Medicine here at Weill Cornell, and Dr. Neel Mehta is the Associate Professor and Director of the Pain Management Service in the Department of Anesthesia here at Weill Cornell as well. They're both experts on the management of pain, and that's what we're going to talk about today, concepts of pain and on how the brain perceives it. We'll start with Dr. Ricky Singh. Ricky, welcome and thank you.
Thank you, Dr. Stieg, and good afternoon to everyone who is joining us on this Monday. Yes, so basically we wanted to talk about pain, how we manage pain in our comprehensive spine center here at Weill Cornell, and what are some of the treatment modalities that we use to get patients functional and moving the way they can. So first, what is pain? There's many definitions that get thrown out of there. The International Association for the Study of Pain describes pain as a sensory or emotional experience that is probably associated with potential tissue damage. The reason I say emotional is going to be relevant when Dr. Mehta talks to you about central sensitization and how the brain perceives pain. But really, everyone describes pain differently. We all say we have different pain tolerances. Some say it might be burning or stabbing, but we use various words to describe pain. Sometimes pain's just annoying. The other day, I went for a run here in New York and I got a little rock stuck in my shoe. Yeah, that's annoying. That's a nuisance. But sometimes pain can be really debilitating, such as spine pain that we treat a lot, or even arthritic pain, again, that Dr. Mehta is going to talk about a little bit later. Next slide. So what causes pain? Our body is geared with many, many different nerves that transmit signals from our fingers, from our toes, from our extremities into our brain. And when that message reaches our brain, that's how we interpret pain. And sometimes our body actually reacts without the brain receiving the information. For example, you touch a hot stove or touch a hot plate, and immediately your hand withdraws. And that reflex arc is actually protective because your body wants to limit further damage. And eventually, when that information reaches the brain, your body says, oh yeah, that was painful. I don't want to do that again. And it remembers that sensation to avoid some of these future activities. Go ahead, next slide. There's two overall arching themes when it comes to pain. One is acute pain, and acute pain is normal. You stub your toe, you get a cut, you cut yourself shaving or something sharp, and your body knows exactly why this happened, when it happened, and the kind of sensations that it feels. It's probably sharp pain. It's probably a burning pain. And typically when the inciting event or when the insult has healed or gone away, those acute pain symptoms gradually resolve. The problem occurs when you have many, many acute pain episodes that can turn into chronic pain. So anyone who suffers from pain for more than 3 months or 6 months can suffer from chronic pain. And what happens in chronic pain is the brain starts receiving information repeatedly. And if you think about those wind-up toys that we played with when we were kids, or I have 2 small kids that play with these wind-up toys, the harder you wind up the toy, the faster you do it, the longer the toy runs and the faster it goes. And the same kind of thing occurs in our brain. The more you send the brain signals of acute pain episodes, your brain kind of gets sensitized to this, and how it perceives ongoing pain differs with future events. Next slide. The most important thing when it comes to pain is the diagnosis. And that's what we kind of pride ourselves on in our comprehensive spine center, also here at Weill Cornell. What's causing the pain? When did it start? How is the patient feeling is the most important thing. Now, through history and physical exams, sometimes we can elucidate the etiology of pain. And once we do, many, many times, we rid the patient of pain and they resume their normal function. And some of the modalities that we use are physical therapy and rest, mindfulness, acupuncture, some medications. And when those things don't work, we go to level 2, which include interventional approaches like injections and innovative techniques. And if those don't work and the patient's still suffering from pain, then we get into advanced therapeutics, such as spinal cord stimulation, neuromodulation, biofeedback. Again, Dr. Mehta is going to talk a little bit about level 2 and level 3 in terms of treatment. Next slide. But in terms of bread and butter interventions that we sometimes employ, things that you may have had like epidural steroid injections. And the reasons why epidural works are because we are inhibiting inflammation. Inflammation is a big problem when it comes to pain because it sensitizes the nerves. Things that ought not to hurt may hurt because the nerve is so sensitive, it's sending pain signals to the brain, and the brain is interpreting that as pain. So we do an epidural steroid injection to kind of blunt that response. The other treatment we do a decent amount of is something called radio frequency ablation. And typically that's for spine pain, but we're using it for many, many other different diagnoses, such as even knee arthritis. There's these small nerves around the knee that we can identify, and we ablate these. Ablation essentially means turning off the nerves or destroying these. But what's relevant about radiofrequency ablation is sometimes after the procedure, patients still say, I feel pain. And why is that? That kind of correlates with a condition called phantom limb sensation or phantom limb pain. And basically the body thinks that the nerves are still there, or in phantom limb that the limb is still there. So your brain perceives information coming from a limb that is no longer there. Same holds true for radiofrequency ablation, which is why it just takes some time for that to work. And the reason we get phantom limb sensation is what Dr. Mehta is going to talk about, how the brain interprets pain, how it modulates it, and how we can still be functional despite these ongoing pain signals. Next slide.
So thank you, Dr. Singh, and thank you, Dr. Stieg, for having us. I'm sure this slide is overwhelming, and it's intentional. It's there to tell you the complexity of how pain manifests. So somewhere on the left side, in the green, it says biomedical and pain experience. That's the sort of epicenter of a painful episode that unfortunately gets untreated or lingers. And you start to see disturbances psychologically, like anxiety, getting insomnia, sleep disorders, fatigue. You start to see biomechanical changes where nerves become inhibited, or you see a likely increase in sensitivity to the nerve. Potentially even you get more stiff, your muscles start to fire less, and maybe even get weaker, or something we call atrophy, where it totally wastes away. So the complexity of pain and how it lingers throughout the rest of the body and its effects is this concept of central sensitization, where it's something that's happening in this at a side is now expanding. And this is really just to say all the different points that we're aware of in trying to mitigate pain experience. So if we want to take one step back and we say, where does it start and what happens next? So the little lightning bolt on the person's left knee is that original knee pathology. We see an X-ray that shows a little bit of arthritis, but now with time, potentially it's spreading a little bit up in the blue towards the upper part of the leg and the lower part of the leg. As a compensation, you may start to get restless leg in the opposite leg. You may start to find that your sensitivity to pain, such as touch, cold, heat, and vibration, gets much more increased, so that something that wasn't necessarily painful may start to become painful. And you even start to get things that are aggravating your memory, your concentration, your sleep, or sensitivity to light and smell. And so when we think about this, we look for signs of this in our history and physical. We ask a bunch of questions as an intake questionnaire and during our conversation, and we're trying to understand, has this sensitization started? And that's why this connection is so important to know when we talk about the brain and all the factors of pain. If there's no central sensitization, we can start by treating locally. If it is central sensitization, then we got to think a little more broadly in central mechanisms. And what are those central mechanisms? Well, this is a wide variety of treatments that could be on there. And some of this may be relevant, some of it that you've heard of, some may be new to you. So cognitive behavioral therapy, the power of psychology, coaching and distraction, meditation, hypnosis, all of those things are starting to come to the forefront and being used more often, thankfully, in our treatments, but also medical marijuana, which has been shown to be helpful in chronic painful conditions. I have a little picture of an intravenous, something like ketamine, which has been shown to be helpful in complex pain syndromes and also depression and PTSD. Low dose naltrexone, one of my research interests, is a drug that stimulates our own endorphins by partially blocking some of our pain receptors for a short time, and therefore can change the nature of chronic pain from central back towards more peripheral. And my latest clinical interest is oxytocin, the love hormone, which has been shown recently to be useful in treating chronic pain, especially that deep muscle and joint pain, and also improving chronic depression and insomnia. So just working at a specific nerve or a specific joint may not be enough. We have to think broader into our brain aspects for treatment of pain. And how do we do that? Well, some of this is tried and true therapies, but some of it is also tailored to you individually. So we're using artificial intelligence in our spine center, where over the course of 2 to 3 weeks, lots of activities is gathered by the patient in terms of pain and work and sleep and exercise. And then through an AI platform, we are now starting to make specific recommendations on types of activity and sleep that could mitigate some of these painful episodes. So again, some research interest that we have going on in our comprehensive spine center. And using the power of virtual reality and EEG combination to one, have a more objective measure of brain activity and relationship to pain, and using virtual reality to distract away from that. Again, other exciting areas of research. I think we lost, and I glossed over one slide. And here is one of the things that we've been doing for some time that Dr. Singh talked about is neuromodulation or spinal cord stimulation. So here in the lower right back of the patient, there's a small little battery that connects to wires that go to the spine. And it starts to interrupt signals of pain that are coming from the painful leg and traveling up the spine to the brain. And so think of it as if you were to bang your elbow along the door handle and you were to suddenly rub your elbow. It's not necessarily healing anything, but can we, quote unquote, fool the brain into having another signal there and therefore creating a lot less pain and a more pleasant sensation being interpreted by the brain? So these are some of the things that, Dr. Singh and I and our team do a lot of here in the Spine Center. And I think as we think about the complexity of the brain and spine and brain and pain, we have to have a more comprehensive, multidisciplinary approach. So that's what we're excited to share with you, Dr. Stieg.
Thank you so much. I just want to make one little summary comment, and I see there's a question from Diana and Susan that I'll direct to you two. I think everybody needs to remember that pain is both local but also centrally appreciated. And when it's centrally appreciated, it can cause stress in your system. I think we all know when we hurt, we're stressed. That induces the release of cortisol. What does cortisol do? It enhances inflammation, makes the pain worse. It's bad for your blood vessels, it's bad for your sleep, and it's bad for your sugar metabolism. All of those things are bad and make the pain worse. In addition to that, chronic pain can affect other components of your nervous system called the autonomic nervous system, such that the sympathetic system is overactive, so you get an increase in heart rate, you get an increase in blood pressure, again, bad for you. The parasympathetic system, which is, you probably all know about the vagus nerve, it slows your gut down if it's not working properly. All of these things, again, are bad. And then certainly when you have chronic pain, you get depressed, and that inhibits the release of serotonin or your responsiveness to the neurotransmitter serotonin, so you become unhappy and you get depressed. So we need to, these are the things that Dr. Mehta and Dr. Singh are working on with you, aside from the local control that they've gone through. we also mentioned the fact that there are adjuvant therapies. Diet can be very important in terms of affecting the way we respond to pain. Sleep is important, meditation, and certainly safe forms of exercise that aren't going to aggravate the kind of pain that you have. With that being said, I'll say Diana was asking about what are thermal procedures. I think that was when you were speaking, Ricky.
Yeah, so thermal procedures are one of the interventions that I discussed called radio frequency ablation. And basically, these are ablative techniques. We're trying to remove nerves or turn them off. We don't necessarily, ablation is not the right term because we're not doing what's called a neurotomy. Dr. Stieg and the neurosurgeons do this, where they actually remove nerves. Basically, what we do in pain management is we just turn the nerves off so that input from some part of the body, whether it's the leg, the spine, or the knee, doesn't travel to the spinal cord and eventually travel to the brain. And it's very effective if the diagnosis is correct. It doesn't get rid of the pain completely, but many times patients come in for their treatment once a year and they go on and live relatively functional lives and return the following year for a repeat treatment.
And then one other question was, I think, asking probably you again, Ricky, to differentiate between high tolerance for pain and desensitization to repeated pains.
Right. Everyone's individual when it comes to pain perception and how they describe it, right? What might be sharp for me might be dull for somebody else. So many patients come in and say, I have a high pain tolerance. What does that actually mean? That could mean a number of things. That could be that they have a lot of serotonin and dopamine that kind of suppress pain information that comes from the body. It could mean that their relationship with pain is a little bit different than mine. Just like Dr. Stieg mentioned, if you're depressed or anxious or sleep deprived, things that may not necessarily hurt you typically will hurt because your cortisol level is up, your stress is up. Diet plays a role in this that Dr. Stieg talked about. So that all goes into how sensitive you are to pain information. And I think there's ways to hack that, with the interventions that Dr. Mehta talked about. You can make yourself less sensitive to pain by doing a lot of these interventions.
Sal Salcido has his hand up. I think you have to direct your question towards Roseanne. Tanya went down here. Tanya had a question, and I think it's going to be a little bit hard to answer your question, Tanya. In this is, what if you live in chronic pain and you've tried everything? You've had spinal cord stimulators. I guess what I would suggest, given the complexity, rather than getting really specific, a video visit with one of our star doctors, or even a phone call once they've had a chance to review some of your studies, and that would probably be more effective for answering that kind of question. Mark, what does pain in one leg cause restless leg syndrome in the other leg, and what can you do to address this? Who wants to take that on?
I think that came up in one of my slides. So it's just thought to be a compensatory, what may be happening with pain in one leg triggering some reactions in the other leg. Basically going after the pain often resolves the restless leg too. Now, that's not to say that you can have restless leg in itself, and there are certainly treatments out there for restless leg syndrome. In fact, some of the medications used for restless leg syndrome are often used in pain treatments as well, like gabapentin. So hopefully that answers your question, Mark.
Sal had a question. I'm not sure whether it was related to oxytocin, the love hormone. Sal, if I'm not asking the question the right way, I apologize. Send another one. But how have you found that oxytocin is beneficial for the management of pain?
Yeah, I think he was asking a little bit about how we use research interests and applying them. How do we find? So some of these studies are actually being officially conducted, and there are clinical trials for that. And some are more what we call retrospective, where we have a clinical thought that something may work. Maybe we've read about it in some of our journals and we want to apply it more broadly. And we look back to see how those patients fared on those treatments. And especially in treatments that um, are difficult to get commercial or financial support to run large scale studies. So how have we applied them? Well, we think about patients that may be ideally suited. So something like oxytocin, is a hormone. We'd want someone that has chronic pain, may have some depression along with that, is not likely to get pregnant, doesn't have some severe mental health disorders, things like that that'd be exclusionary. And then also we want to make sure that the more basic things have already been tried before jumping to something a little bit more experimental. So hopefully that answers the question there.
That was one of the questions I had for you, is when is it appropriate for the patient to start thinking about, I've got to do more? Patient comes in with local back pain, you do some sort of an injection or physiatry, physical therapy, and they get better, that's great. But the pain persists. When do you as doctors start thinking about more integrated things like mindfulness, meditation, talking to them about diet? And do you do that, or do you have other people in the spine center that do that with the patients?
I would say what's nice about spine pain specifically is that by and large, most patients will suffer from acute episodes. And a lot of these episodes are self-limiting, using therapy and medication, some rest, some of our basic interventions. A lot of times the patients get better and, again, they live their life fully and functional. It's the patients where we have, quote, fixed the problem, where it's a big disc herniation. We do a couple of epidurals. I send to my neurosurgery colleagues. They remove the structural problem, yet the patient still has pain. And those are the more challenging cases. And, with Neel and I at the Spine Center, one of the discussions we have is, at what point do we tell the patient, and how do we say this sensitively, the pain is in your brain. It's not in the spine anymore. And we don't mean that to be pejorative. We mean that to mean you're perceiving pain signals that aren't there anymore. So the normal treatments that we're using aren't working. And that's where we need to lean on our integrative health center here and our acupuncturists and our mindful specialists. Like you said, diet, nutrition, sleep, all these things come into play. And I wish we could have that conversation with every patient. But, in a big center like ours, we're lucky to collaborate with other practitioners, but that's what we refer to our colleagues to help us figure out the source and figure out the treatment.
Fran was asking about the experience where, having had a lower back fusion and now they've developed upper spine pain. Common experience for you? What do you do in that scenario?
Yeah, I think this is something that unfortunately happens with or without surgery. The presence of spine pain could be muscle related, could be joint related. It can be referred pains where it's actually occurring in one location but manifesting in a different location. This is why pain is so fascinating to all of us, is that how it occurs and what's the root cause is really part of the journey. So obviously we would look at the basic things, make sure something isn't structurally wrong, and then start to incorporate the history and physical exam to target some of those treatments that are more focused on that upper back pain.
Sally's asking about the application of gabapentin for the management of spine pain.
Go ahead, Neel.
Ricky. Sure. So gabapentin is an interesting drug. So it's been around for a long time. It was originally an anti-seizure drug, then was discovered in lower doses to be useful in the treatment of nerve pain, specifically for the attack of shingles. It's something called post-herpetic neuralgia. And then we started to really think that a lot of nerve pain can respond to that as well. And so in spine pain, especially in pains that are going into the arms or legs or so, could gabapentin play a role in sort of dampening down some of that excitability of those painful nerves? So that's the thought. It's a drug, sort of more of a longer term usage rather than just for an acute, like short-term pain relief.
There's a question about green case therapy. That didn't ring a bell.
I'm not sure if that was referring to laser. I don't know. Sometimes they call it green laser.
Yeah.
I don't know, unless you're thinking something else.
We'll ask somebody else. And there's one comment here. I want to make sure that everybody understands, when we say the pain is in your head, is that we feel again, that the pain is no longer in the local site, and we have to help you, the patient, understand how to manage the way you're perceiving the pain. And we're not saying that it's not there. It's just that there's nothing else we can do locally. So we've got to then start trying to treat the pain syndrome from a central perspective, which means it's, if you're feeling it centrally, you're feeling it in your brain.
And one of the questions we ask patients, again, it comes back to your relationship with pain, how you perceive it. A lot of times we give patients simple injections into their knee, and patients are very fearful of these local injections. Yeah, when we start prepping them and cleaning their skin, we see big tattoos in their lower back. And I ask the patient, did that hurt you? And a lot of times they say, no, I wasn't sedated. I was excited to get this big tattoo. But that just goes to show you it's about experience. And they might have had a bad experience with the needle, but not a bad experience with a tattoo. And that's why it doesn't hurt them as much. So, and that's kind of the reprogramming that Neel and I are talking about, is either using virtual reality or artificial intelligence or some of these medications to kind of dampen that influx of information to the brain so you don't perceive pain and get anxious about it before it even happens.
I'm really surprised nobody's asked more about marijuana for the management of pain. Can we, I don't know, I know other doctors that prescribe it. What are your thoughts about its utility?
Well, I think medical marijuana, because it's been around for a few years, I think sort of some of the hype has come and gone. In a nutshell, I think it has relevance in certain chronic pain conditions, but it's not the panacea that everybody thought it was going to be. Just like a lot of the therapies, there are great candidates. There are some that it has sort of less benefit, and there are some that actually found it to make things worse. And so, it's easy to try, but we should also tamper expectations there.
Well, what's interesting is there's good science behind it. People talk about the runner's high, and the runner's high is the result of the endorphins that get released after running. But in addition to that, they stimulate the natural cannabis receptors that you have in your brain, and that's why you get the feeling of joy and relief. And the excessive exercise doesn't hurt as much. Clearly, we don't understand the full mechanism. Otherwise, it would probably work more if we used medical cannabis regularly.
Yeah, that's that low dose naltrexone I was mentioning. Also, kind of works on a smaller pathway like that. So, sorry, Ricky, I cut you off.
No, go ahead. And even part of the medical marijuana is not just the THC component, which we all kind of associate with marijuana. It's the CBD aspect, and we know that is anti-inflammatory. That goes back to what we all were talking about, was how inflammation modulates how our nerves work. So the more inflammation circulating in your body from eating carbs and sugars or not sleeping or being stressed, make you perceive more pain. And CBD is just one kind of way to suppress that.
Yeah. Well, it looks like we're coming close to the end of this. I want to express my appreciation to Dr. Singh and Dr. Mehta for taking the time. I want to express appreciation to all of you that have signed up for this webinar. It's been great fun. I'm glad to see that there's many questions. I think we all appreciate how complex the understanding of pain is and the treatment of pain. It's the most frequent reason for people seeing doctors. So it's everywhere. It's all around us. And you need to see specialists like the two that we've had on today in a comprehensive center where we can take a full armamentarium of therapies and hopefully relieve you of any pain that you have. Thank you so much.
Thanks, Dr. Stieg. Thank you, everyone.
Thank you, Dr. Stieg. Thank you, Ricky.
Take care, everyone.